The director's here in front of us, and we have people here with us on my side of the table as well this morning as we begin. So, Director, please begin.
All right. Good morning. I got to stick this closer. Good morning. Valerie Hoon, Director of the Department of Mental Health. We're here to present our budget today. We've had an opportunity to talk with most folks, so instead of kind of giving you an overview, I think we'll just dive in if everybody's okay with that. So if you will start, we'll start on page 2. This item is our utilization increase new decision item. It is our largest new decision item. It covers all of our divisions. And so I'm going to kind of talk through this in an order. This new decision item also includes offsets, which is a little bit unusual. Typically, we would do core reductions later. Historically, we would do core reductions later, but there are reductions included in this new decision item. So we will go through all of that, and we've got it all broke out on a page to follow along. So.
Okay, if you can, Director, I've got some questions here.
Okay.
I know I'm going to go ahead and go through those, and you'll remember them, but I'll stop. I want you to know what I'm going to be asking as we go through this area. If utilization exceeds projections, how will the department manage the shortfall? And we've discussed that a little bit. We need to discuss it today in committee, right? And the DAHAB, you recognize, I'm sure people have been talking to you about that proposal, as well as I've had several people talking to me. How will DAHAB staffing ratio change impact provider capacity? Okay, what does the department see there? How could the reduction in SDS rates and DAHAB rates would the department project affect workforce that's in that area? You know, I've had several people discussing that with me. It goes back to, we know that I come out of education, whether we pay for people sitting in a seat or pay for membership, that kind of thing, right? And then what factors were considered in determining the proposed reductions in SDS, DAHAB rate? What factors were there? And I think we've discussed a little bit of that in the office, but well, we do that, so I'm asking you to fit those in at the right place, but there's people even sitting up here with me that have come to the office, and I don't know whether they talked to you, but I think it'd be good if we just try to discuss that as we go through the book. Okay?
Absolutely. And then we can get almost all of that covered off of this new decision item. So the good and the bad of getting it all in one place. Okay, so I'm going to start with this because I'm going to get some stuff out of the way off the top. So the very first thing you notice, there's a difference between the department request and the governor recommended, and we will go through what that is when we get to the following pages. A couple of those easy changes, though, are there is an add in E&E GR of $702,000, and then there is also an add on the other side, other funds. That is for our ICF provider tax. So we just need that. That is a non-count that we add that we use to pay our provider tax. The second thing I want to point out in our other funds, because there were no other funds in the department request, the other funds here that aren't provider tax funds are the Mental Health Reinvestment Fund. And the Mental Health Reinvestment Fund receives its money via a transfer from in Health and Senior Services budget from the Cannabis Mental Health or Health Reinvestment Fund to the Mental Health Reinvestment Fund. So the Mental Health Reinvestment Fund's origin is the cannabis dollars. So that is our other fund issue here. And you will see that sprinkled throughout our budget. So we just wanted to make sure that you understood that fund gets its money from a transfer in health budget. So that needs to be there in the future. The other thing, I think, with those two things kind of out of the way to explain the differences between the department request and governor rec, the best place to go is page 5. And we're going to start with our Division of Behavioral Health. Actually, we're going to start with your first question. If utilization exceeds projections, how do we manage the increase? And so we do have a supplemental in front of this committee that has increases in our utilization. So if there are, we put that supplemental forward, and then you all would consider that. And we adjust that supplemental through the supplemental process based off of actual usage. So our first supplemental estimate, we have 1 month of expenditures, right? Then we usually do another update with the governor's office in December, both for our supplemental and our utilization new decision item, when we've got more expenditures, more history in the program to give you a better idea. And we will continue to look at that throughout the year. So that is typically how we manage utilization overages when we have them.
Okay.
Because
When we
these are
look at the
Medicaid
people
dollars.
discussing wait lists, and that, to me,
Yeah.
that's still a piece of what
Yes,
we're
we're
discussing
gonna get
here.
there, yeah.
We've went through a time where wait lists have went
Right,
to zero.
yes.
And I guess for myself, and as well as I think other people on the committees have this question, when we do the things that we may end up having to do
Right.
this year or next year with that, wait lists begin July 1? Or would wait lists possibly begin in November? Would they possibly begin? And I
Both.
understand okay, go ahead.
So that's going to depend on how it's funded. And so that in this, I will just talk about that now, and I will try not to talk about it later. So this, on the behavioral health side, there is not a wait list, so to speak. So that is a state plan service, just like a physician service. So we usually have an increase for kids because that is the mandatory population that we cover. So anyway, think about that like you think about just a Medicaid supplemental. Okay, then you go over to the developmental disability side, and that's where we have the waivers. And so you determine the capacity. We don't have to serve everybody that comes in the door for the waivers. We can have a wait list for those services, and that wait list is based on your time into the system and your acuity level. That's how when we get funding to address a wait list, we look at your acuity level, and then we look at your time in the system. So anyway, that's just to give you an idea. Right now, this budget includes funding, the governor's recommendation includes funding for 100 residential slots. We also, every year, have something called turnover slots. So if a slot terminates throughout a year, somebody moves out of the state, somebody dies, that slot is available in the next year for us to use again. And so we won't know until the end of this fiscal year what our termination of slots will be, so that we could have those turnover slots available to use. So we do factor that into our overall number. So for example, on the in-home side, we had estimated that we would need 250 slots on the residential side to not have a wait list. The governor funded 100 slots. We factored that into the turnover slots into that 250. So we know we'll have turnover slots. We know we'll have 100 new slots. And when we run out of those slots, we'll start a wait list. On residential, I'm going to say, and this literally is throwing a dart in the wall behind my back, January. January-ish would be when I think we could start a wait list there. On the in-home side, the same thing. So for our in-home waiver, and that one we had requested, I wrote it down. In the department request, we had requested 1,049 slots. Again, we don't have a lot of information at that time. And we adjusted that in December to 495 slots. So we think we would need 495 slots for the community wait list next year. We will have turnover slots. So best guess, I'm going to say September, November. Somewhere in there, we would start a wait list. So that is what I'm thinking in terms of wait lists.
Senator Searpoint.
Thank you. This isn't really what I was planning on asking, but so the residency, you say you don't find out about an empty bed until December?
No, what we do, like residential is what you're talking about. So those will happen all throughout the year, but once a slot has started to be used at the beginning of the fiscal year, that slot is assigned to that person. You can't reassign it to somebody else halfway through the year.
But if they leave, the funding does stop.
The funding stops there,
Okay.
yeah. But then we would use that to offset the other costs, which, again, we don't have a supplemental, general revenue supplemental this year for Division of Developmental Disabilities for those services. Yes. Okay, all right.
Senator Murphy.
Okay, we talked about this yesterday.
Yes.
And I'm still trying to wrap my
Yes.
head around the wait list here. So again, you're anticipating, I just want to make sure I have these numbers right. So the funding request is for 100 residential slots.
Yes.
And you're anticipating you need how many?
250.
250. And so you're anticipating for that, you're starting a wait list in January.
Yes, if you were trying to pin me down a year ahead of time, I would say January.
Okay. So talk us through the implications of having a wait list.
So how a wait list works is once we go on wait list, then we have individuals that are coming into the system all the time. And so everybody gets access to case management services. If you're Medicaid eligible, you have a developmental disability, you will be assigned a case manager. And that case manager, we do assessments on you to determine if you are eligible for these waiver services. So not everybody with a developmental disability ends up being eligible for waiver services. Then after we make that determination, we also look at your overall acuity level, your service level needs, and we'll work with you on different types of services. So if you want a job, we'll work with you on getting employment services. So it just depends on what that is, okay? So take that into the factor. If we have a wait list, we go on wait list on X day, you can be told that you are eligible for these waiver services. We can even work through what that looks like for you, but you will not get access to them until I have funding for the wait list.
Okay.
So if you need a residential service because somebody in all of your guardians and your family, you have no family left to take care of you, I don't have services for you.
Okay. So you're not anticipating wait lists for behavioral health?
We don't, it's a state plan service, so you cannot look at it this way. A waiver, you can have a wait list. State
Okay.
plan services, you can't.
can't. Okay.
Right.
Okay. Thank you.
Thank you.
Sir Boy.
Thank you, Mr. Chairman. One follow-up question on that. If this anticipated wait list that you're kind of built to think what happen next year, built into that is if any of these day hab providers go out of business, they may influence the size of that wait list a great deal if those families then look for other
No, I
ways.
can't factor that in at
You
this
can,
time.
okay.
Okay.
Okay, I've got one more. You saw Adam come up here, and him and I talked about this in the office. I don't remember. We know it probably wasn't my brain power, but explain to me, and the rest of the committee may already know this, when we look at people receiving these services, and you've discussed it a little bit, just make it a little bit more cinder black, able to understand. A person that's on Medicaid receiving services within this list of people versus the people that are not Medicaid eligible and their touch of the system. Isn't there, both can utilize services. How's the difference in the way they're treated at the point where they're putting on that list, et cetera? Is
So
there anything in difference?
We do not maintain a wait list for waiver services for non-Medicaid individuals. For non-Medicaid, no.
Okay.
So if you are not Medicaid eligible, most of our case management now is done at the local level. So we have, I'm going to say 40, that's not exactly correctly, but we have about 40 case management providers across the state. Some of those case management providers are your local Senate Bill 40 boards that operate out of your counties. Some of those counties will use their property tax levy to support individuals with non-Medicaid services. So if you are getting non-Medicaid services in the developmental disability space that are government funded, so to speak, those are more likely being funded by the property taxes at the local level. And that's all the Senate Bill 40 boards. You don't have to do case management to fund local services.
Thank you. Learn something else. Yes, sir.
I have a question on the pay rate to those caregivers. Can you explain to me when did they get a pay raise? What is the level that they're paid now? What is the projected level? Are they? I'm asking.
No,
that.
I can follow this question. So if it were a simple answer, I'm gonna spread this out a little bit because the department does a rate study every year, or not every year. We do a rate study every 5 years, and then we can trend that rate study. In that rate study, we look at the Bureau of Labor Statistics wage categories for people that do the type of work for the services that you're looking at. So every different service is going to have a different wage that could be paid, okay? And then we factor that in, and then the providers ultimately determine what that wage is. Now, how do I get a test of the system? So we do something in Missouri called the National Core Indicators State of the Workforce Study. And that State of the Workforce Study we do with, I want to say, 25 other states. And that study surveys our providers. We pay our providers for completing that survey. They have to ask us for them. They have to tell us they did it. We will pay them for completing that survey. And then we can keep track of what those wages look like for a direct support professional. So we can share that study with everybody. But we just got the study for 2024. And averaged out across all of our providers, direct support professionals make $18 an hour in Missouri. Now that will vary between different services. But and I will say our largest service will skew that. So our largest service is our residential service. So that is where we spend the bulk of our funds. That's where the bulk of the direct support professionals are working. And that will skew it, and that is 18.
So it may be different from year to year.
It will, yeah, oh yeah, it will be different. And it has been going up steadily. We have invested, between the General Assembly and the governor, we have invested a lot of money in rates over the last 5 years, and predominantly done that to get that wage up. I will tell you that CMS has a rule out there right now that says of that rate that we pay, they expect 80% of that to go to direct care wages. Now, ours is not that. If you look at our rate study, it's more like 60% goes to direct care wages. So I am not sure where that is going to land at the end of the day. It looks like they're going to back away from that requirement, but as of today, that is the requirement that the federal government is heading to make sure that providers are passing through dollars as wages.
So what you're saying is, though, if they were given a raise, say in '25, will that rate come down, or will that stay the same?
It depends on where they are getting their services. So, and I will talk through the ones that the rates are coming down in a minute.
Okay.
But that is not all of our services, or all of the individuals in services. Okay, so I'm going to check the first one off the list. And I'm going to start talking through, we're going to start on page 5, and this is the Division of Behavioral Health. So we have an increase for mental health youth services, and that will be an increase of 2,958 clients. This is actually an increase over the department request, so we ended up at 25 million total funds. Department request here was 22.6 million. So again, I explained we continually look at those numbers. The next item here is outpatient competency restoration. This is 50 individuals. This is also included in our supplemental. We use outpatient competency restoration for individuals that are in our county jails today that are waiting to get into state-operated services. They are incompetent to stand trial. So this gives us another opportunity to help get folks out of the jails. The next line is place of service. And this is to help folks transition. We have about 4,000 Missourians that are in nursing homes with behavioral health conditions. These dollars are there to help us transition individuals out of nursing homes. And so that is what the place of service dollars are for. This was actually funded in last year's budget, but it was funded with one-time funding, so we're asking for this to be picked up with general revenue. This is a Medicaid-funded service.
Sounds new.
It's not, though.
It's not.
We started it
So
last year.
well, that's what I'm calling it.
Okay.
Okay? So at this point, how far along is this program
We will
on the
give you
start?
that update. We will get you that update. I know we have providers that are doing this. I don't know the number of people. When you
Okay.
start a new program in
So again,
July.
it's private
Right.
providers
Right.
that are contracted one way
Right.
or another with DMH providing
And the
these.
intent is that they will go in and deliver both CPR services in a nursing facility, because that is not something we had historically been doing. And
What
we'd-
services?
Psychiatric services in
Okay.
a nursing facility, because that's not something we had historically been doing, and our nursing facilities were having a hard time maintaining staffing and even staying open because of that. And then the next thing is to help case manage folks so that they can actually transition out.
Okay.
That's really quick. Thanks, Director, for being here. I'm just looking, this is just fuzzy math for me, but can we go to the outpatient competency restoration and just tell me about that a little bit? You have 50 individuals there. It's 120,000 basically for that line per person. Can you walk me through what that line is?
Okay, so today, this is not an available service. I mean, we have the ability to do this via statute today. We actually just got that passed 2 or 3 years ago. I can't remember. And that allows a judge to say, instead of you coming to the Department of Mental Health and going to a state hospital, which are full, we have 524 people on a wait list to get into those facilities. Instead of doing that, we want to try outpatient restoration with you. And so we would contract with a provider to do that outpatient restoration. The reason it seems high, we have to pay for, these are not folks that have a means to pay for their lodging, so like we do in the state hospitals. But we can earn Medicaid on the treatment side of it. So that's why the GR Fed seems a little bit wonky there.
Okay, thanks.
And
Senator Nuremberg.
actually, yeah, I have the same question. But another one, go back to how many individuals right now are waiting for that
Okay.
inpatient.
I think
So-
524 was maybe 2 Thursdays ago. So what's our number? Is it 528?
Okay.
So 528.
And in terms of where those individuals are today, do you all have a good idea if they're in hospital beds?
They are not
jail
in hospital
cells,
beds. They are most
in-
likely in jail cells. Some of them may be out on bond in their community,
So the vast majority are,
in jail.
what number do you know?
We can get you that. It's going to be high, probably over 5.
So how do we decrease that?
Well, outpatient restoration will help us decrease that.
There's a bill for that.
Well, that passed, yeah. There's
And-
also,
and there's some more.
assisted. There's actually a couple other bills
Yeah.
out there, assisted outpatient treatment. That's another, basically, these are options that we are giving to the court system to say, instead of putting them into this incompetent to stand trial list, which now is very large. Actually, Senator Crawford has another bill, a misdemeanor diversion bill too, so that they have a choice instead of, if you've committed a non-violent misdemeanor, that gives judges an opportunity, instead of going the incompetent stand trial route, to go the route that allows you to just get treatment in the community, which is what you really need. So there's a lot of different things that we are working on to address the issue.
Okay. I'm asking because this is, I think, a huge concern that we continue to have individuals that have been, I mean, some, I don't even know how many years. I mean, I remember talking to my judges that there was some individuals
We're
that had
still
been
calling
there.
it a 14-month and that's from the time that the judge commits you to us, to we can get you into the facility. There's time before you, from your arrest to when you get there. I don't know what that number is, because there is time between arrest and us even knowing you exist that is large.
But we do
sometimes.
have those individuals that are a year plus.
Yes.
Still, that have not been charged
Absolutely.
with a crime. And these are the things that, it's really hard for me to even fathom that we continue to have individuals who are being held, quite frankly, unconstitutionally, without charges pending because they're not competent to stand trial, and these are just lawsuits waiting to happen. And again, like when we look at how much this could end up costing the state, I mean, this is a huge concern. And I mean, we're hearing it from, I mean, every single judge I've talked to.
There is a matter currently before the court about this.
Okay.
In Missouri, yes.
Where's that at?
That it's been filed. It's in the Western District, Federal Western District.
Okay. But again, this is just something I really highlight, for the committee to pay attention to, because this is a massive issue going on right now. So still 500 and some. I mean, these are the numbers where they're not going down, they're only going up. Every single year we continue to see this go up. And I'm concerned when I see further cuts in the budget that the problem's only going to get worse. So, I mean, it takes every side of it. Again, changes in statute, obviously, to get more people care. But man, if we can't back it up with funding either, then unfortunately, I think we're going to be back here next year and we're going to see that number continue to increase. So, okay, thanks.
All right. Okay. The next item here is community-based placement. So this is adults into the community for behavioral health services, 15,503 adult Medicaid growth here. The next one is C-STAR. This C-STAR one is also in our supplemental. So this is C-STAR expansion. Instead of general revenue here, we are using the Mental Health Reinvestment Fund, the Cannabis Fund that I talked to you about earlier. And then the last one is the CCBHO FMAP switch. So one of the great things about the Certified Community Behavioral Health Organizations when we started that was we got an enhanced match rate. And that enhanced match rate actually ended on September 30th or October 1st. I know that makes a difference, but in my brain, I don't know which one of those it is. Yeah, September 30th, thank you. So that ended September 30th. We actually got funding to basically get this fully corrected over the last few years. This is just the rest of what we need to get it corrected, that match rate. So that is all that is. Okay, now we have the offsets in the Division of Behavioral Health. So these are the reductions we are taking to help fund these increases. So for the first item is the Greene County Youth Resiliency Campus, and that's $1.8 million. So this is to fund treatment, and as you can see in that very first line here, this is for kids. When we have Medicaid eligible kids, we come and ask you for that through a regular utilization item. So we're just saying when this is built and they start billing, it actually hits us on that mental health utilization, youth utilization line. The next item is for the Kansas City Assessment and Triage Center, and this is a $1.3 million reduction. This is Kansas City Assessment and Triage Center was our first behavioral health crisis center in the state. and it opened, I'm going to say 9-10 years ago. Anyway, that Behavioral Health Crisis Center, we had also included funding for wraparound services. So this is predominantly non-Medicaid wraparound services for that specific Behavioral Health Crisis Center. Our Behavioral Health Crisis Centers do not have that. The rest of them don't have that in the state. So we have requested that as a decrease. And then the last one, youth-supported community living. That is our non-Medicaid dollars that we were using for youth-supported community living. So that is an explanation of the there is not included in this, because from the department request to the Governor Rec, it does not include $8.8 million of general revenue for 710 individuals that are in adult crisis open access service. Those are folks that do not generate Medicaid. It's like before you become Medicaid eligible, or who may not be Medicaid eligible but are accessing our crisis system. Okay, then let's move to the Division of Developmental Disabilities. So I think we've talked about wait list. From the department request to the Governor's Rec, that is the largest difference, was that there is going to be a wait list. We do have lower numbers than were included in the department request, but we've talked through those. So the first line here is the cost to continue for care plan utilization adjustments. And so this means that we give you a budget for what things cost. And we do that, for example, this is for our folks that we added in FY25. We base that off of FY23 actuals when we come to you. And so what we know is that the cost per individual in our FY25 request versus our actual spend for those individuals was higher. And so we're asking for that increase in a budget. That is a utilization increase we're asking for. For an example, we had budgeted residential at $536 per day, and it actually came in at $619 per day. So we need an increase to $619, and that's what this funds. Also, if you look at our community support waiver, we budgeted that at $101 per day. We budget per person, we don't budget per service. And that actually went to $137 per day. So that is why this item here, $21.3 million, is just to fund the care plan utilization costs of the people that we added in FY25. So the next item in FY26, when we do the budget for services, for new waiver services, we prorate those. Last year, the House did not prorate the community support waiver. They put in the full amount. So we assume when we put in our department request that you're only going to have so many people for 12 months, only so many people for 11 months, only so many people for 10 months, and then we come in and ask you for the rest of it the next year. The House funded the full community support waiver without that factored in, but they did not fund the residential waiver that way. So this is the funding to pick up for that full year cost of the residential waivers. The next item are our crisis residential service slots for FY27. This is our residential waiver. These are those residential slots, and that's at 100. The next three, nursing home transitions, 27 individuals, children's division transitions, 39 individuals, MOKID transitions, 11 individuals. So these are mandatory populations that we have to cover in the waiver. So we can't have a wait list for these folks. So they have to automatically come in every year. So if we had a full wait list, we would still ask you for these these places. Our DD Health Home program is a program that is also growing. We have included this in our supplemental as well. There is also additional federal authority that we need. So last year we had, when the House was trying to align our federal authority, they cut about $100 million, I think. This is how much, and of course we're basing that off of 2 years worth of we're really far behind when we're making those, having those conversations. So we just need this federal authority back. This just matches our general revenue. That's all it does. And then the last one is our provider tax, which we talked about. So that is the new decision item. And so that's $39 million of general revenue. That $39 million of general revenue is offset with the following changes. And so these are the reductions. The first two are two services that we are eliminating from our waiver. When you eliminate a service from the waiver, the people that are on the service at the time that you eliminate, you transition to another service, but in the future that service is no longer available to anyone. So the first service is a very small service. We have 7 individuals that use this service. It actually is more of a one-time service anyway. So since it is such a small service with little utilization, and it's probably more work for us to write it into the waiver than it is people using it, we are going to take that out. The next item is our community specialist line. We had 300 individuals use this service, so we will need to transition them to a different service, and then in the future, this service will not be available. We have a lot of conversations with CMS, our federal partners with the waivers on this. They have a hard time understanding the difference between this service and support coordination service, case management service. So it's just honestly easier for us if we eliminate it, and it's not a heavily used service. So the next two are the two that probably do get the most attention. The first is the reduction of self-directed support rates. And this reduction to self-directed support rates will take our rates to 92.6% of lower bound rates from the 2025 self-directed rate study. Self-directed services represent about 39% of our in-home budget today. So they are the largest user of that in-home line. And of that, what this will do, it will take the rate there's 3 rates here. I'm just going to use one, but we can go through all the other ones later, but just for purposes of the conversation. We are going to take that rate from $8.25 per 15-minute unit to $6.51 per 15-minute unit. We bill on 15-minute units in the division. That results in the $6.2 million worth of savings here. Now, reduction in SDS rate impact on the workforce. That still equates to, and I gotta get this other piece of paper out because I did not write that down on my piece of paper here. That still equates to $26.04 per hour, and those dollars are used to pay direct support professionals. And as we discussed earlier, the average direct support professional pay in this state is $18 an hour. So understanding that, and understanding that that's what we're paying in our residential setting for individuals to work in our residential setting. When you ask me what I think the impact on workforce will be, I'm not sure that I can see an impact on workforce at this time. We will monitor that, and we will continue to look at that and get back to you. But at this time, based off of the data that we have, I don't see that impacting that workforce. Moving on, now, please understand, it is an impact to the families, and I don't disagree with that. But
Who was first? Senator Newberg?
I don't understand how you can say that there wouldn't be an impact on the workforce.
I think that there's workforce out there that can fill in if somebody does not want to, that is skilled in this work, that meets that $18, that is currently making $18 an hour doing the same job.
Because we hear, and again, like, you know, I remember being in my district and learning a little bit more about this, right? And in a home, and I was learning all about this. I think it's so important. Again, big supporter of SDS and families being able to make the decisions that are best for their family, choose their providers, all of these things, right? However, what I'm hearing from these individuals is that they, every place out there, again, we've had these conversations, right? Whether it's, you know, working fast food or Sam's Club or Costco or the Dollar General Distribution Center, everybody's making more than that. And that's been their thing, that they will not be able to find individuals if this
Right.
is the
I'm
rate.
very familiar with that. I do run facilities across the state, and I do support individuals with developmental disabilities in the community, and I pay $16.66 an hour to start. So I am very familiar with how hard it is to hire people to work in this field.
But it's an interesting,
I have 1,000 vacancies right now.
it's just interesting to hear that you think that this wouldn't impact the workforce.
I think everything impacts the workforce,
Okay.
but I think that this is at a different spot with this workforce than even I'm experiencing at the state level.
Okay.
Senator Henderson?
Thanks for coming by and explaining some of this issue. So you really think you can fill all those positions, correct?
I mean, that is the family hires and fires. So
And-
they will have to work through that, and they will have this, they today have the same challenges that everybody in this field has, including the state.
Did you not mention to me yesterday that sometimes it's family hiring even though they're family members?
Right, as long, we will pay for anybody that is not a guardian.
Yeah,
So
okay.
as long as you're not a guardian, you can work in the home and support the individual.
Does that happen quite a bit?
I am not sure. We don't keep track of it that way.
I see heads shaking behind you that like it probably does. And so that was my question, because I thought that would probably help somewhat. It is a decrease in what they'd make, but if they're hiring family members, I could see how they would still come in for
There
that.
are other, it does broaden the universe. They have a large hiring universe. Okay?
Senator Crawford.
Just a little bit more clarification on that. So that those shifts down in those wages,
Right.
does that all go straight to the provider, or as part of that administrative, or is there a breakdown there, or is that?
So the only part, so the wage is, that wage includes is what you pay for your Medicare, your FICA, what everybody else. So just like everybody else, when you take a job for $15 an hour, you know you don't make $15 an hour because the taxes that come out of that, so.
But you don't have any administrative
No,
cost.
no, we
with
actually, the state
that's
actually
what
pays
it
for that
goes.
separately. Yes.
Okay, so that's a different line item.
Mm-hmm.
And then just a comment. It's I'm hearing quite a bit of pushback. From
Yes,
we talked
absolutely.
yesterday.
We are also.
I'm sure you are too. Just a comment about with minimum wage going up to $15, that may, and this coming down, that may be a problem. And do you have a plan if you start losing a bunch of providers? Do you kind of have a backup plan, or not really?
We have been through this. I want to say this. We have been through this before, and we manage the way we can manage. So we have cut rates before, and the rates weren't at the level they are today.
Okay.
So this is not a new thing for us to cut rates.
Okay, thank you.
Senator Searpoint.
Thank you, Mr. Chairman. Are we on the DAHAB line?
Nope,
or is
I'm
that
gonna do
next?
that one
Okay,
next.
I'll wait till you get done.
Okay. So then the last line here is the reduction of DAHAB rates. And that reduction is a result of changing from 1-to-1 staffing ratios to 1-to-1.5 staffing ratios. The DAHAB service, we also have 3 rates. We are only looking at reducing we have 3 different rates. They all have a 1-to-1 staffing ratio. So we have a DAHAB medical rate, and we have a DAHAB behavioral rate, and those rates are a 1-to-1 staffing ratio. And then we have a more like acuity level rate, DAHAB, and that's the one we are talking about. And so what we are looking at doing is reducing that staffing ratio, which we pay today, from 1-to-1 to 1.5. How do you do that? You do that by lowering the rate. So we talk about it like a staffing ratio, but what we are doing is lowering the rate. So we will be taking that rate from $10.81 per 15-minute unit to $7.21 per 15-minute unit. And for some reason on this one, I wrote down that by the hour. That's 43.24 per hour to 28.83 per hour. The DAHAB program does represent 30% of our in-home budget. So self-directed is our highest at 39%, DAHAB is at 30%. Okay.
Senator Searpoint.
Thank you. And Mr. Chairman, you mentioned a lot of these things. I just want to drill in a little deeper if I can. And I appreciate your questions earlier. I think they're on point. So those 3 different layers of reimbursement and the way you're changing it, you're changing the one, which is the most common. What percentage of clients are in each category?
And I'm going to have to get you that because we actually did not include that. But we knew it was coming yesterday. We just didn't have enough time to get that figured out.
But I guess the first,
tell you.
the lightest, the
This
one
will be
going one to
the highest percentage.
by a lot, you think?
I can't answer that. I don't know.
Okay, and could you also have your folks bring me how you determine which level they
Yes,
are?
absolutely.
So this was included in the study. I guess the study was back in 2017, 2018?
Yeah, we started that. Our first rate study was done in 2017, yes.
And being implemented now. Between then and, I picture providers seeing that, and since it wasn't part of the equation, they just kind of let it go. Now suddenly it is part of the equation, and they didn't fight it back in the day probably very strongly because it didn't really matter, but now it does.
Right.
And that's what I find troubling is this has been there for a long time.
It has.
And if I understand, you're doing another Mercer study now. We talked about that a little bit.
We are doing another study. We've actually started the DAHAB study once the governor recommended budget came out. We are working with our actuary firm to work on a rate study considering a 1 to 1.5 ratio.
And as I said yesterday, there is a perception that maybe we're trying to defend what we did with this rate study
There is
rather
a
than
perception of that.
letting it. How much does that study cost? Do you know?
How much will that study cost? We will get that for you. We know they will bill us for it, so we know.
I mean, do
They
we
give us
have
a
to
plan.
refund that, or is it just in an account that you guys have?
Well,
money
no,
for?
we have funding that we use for Mercer to do actuarial work for us. All the state agencies do, and so we have what we plan to spend every year on that. So it's not, we do fund it though, but it's part of our overall budget line.
Okay. The problem I'm fearing is we talk about employees and minimum wage and all that stuff, and that's important. But what I found when I go to these places, this is not just a job. I mean, you almost have to have a passion for this to do it at $18 an hour or $21
Or 1666.
Yeah, you really do. I mean, it's not just McDonald's and frying hamburgers. You're really dealing with people. Some of the jobs I would have a difficult time doing because they're not pleasant. And I just want people to realize that this is not just money for employees. It's actually people who are dedicating themselves to help folks that really have significant problems. And
They do.
we're kind of playing with fire here, I'm afraid, because if some of these places close, your residency centers are going to be really inundated. And all these families are going to have to deal with this in ways they haven't had to do it before. And so I just want us to be aware of that. And of all the places to cut, this seems like a terrible one to do. It seems to me that we could look at economic development or DNR or someplace to find a few $1 million to restore this stuff. So I just want to work with everybody, and I want I just want the budget committee, because I know I talked to some, and some aren't aware of this DAHAB, don't realize the significance of it, and I want them to understand that this is, and as a Republican, I'm saying this, it's really something that touches people very closely.
This is a third cut. So
It is.
it's a third of their revenue.
It really is, and the absentee issue, which is, I've heard about since I've been in the legislature.
Absolutely.
As the chairman said, it's like a school, you pay for staff, they don't show up, schools get paid, these folks don't. And that's a third, and here's another third, and it's going to be very painful. So, thank you.
Senator Nuremberg.
Well, thank you, Senator Searpoy. Honestly, I really wanted just to echo that same sentiment. You know, after we talked yesterday, I was able to circle back with my providers and the real impact that this is going to have. And we know for everybody that that least restrictive environment is best for everybody, for the individuals, for the family members, and it's the most fiscally conservative thing to do. I mean, that's the whole point, that this ends up costing us more money. So I'm talking to my providers, and they're sharing that this, while so many are so grateful for the work that we have done in recent years to increase rates, now we're seeing this cut to DAHAB by 33%, and they're telling me that they are going to have to cut slots. And where do those individuals go when they don't have access to those services? So again, I really echo Senator Searpoy in saying this is not the spot where we should be cutting. There are other areas. There are other areas, and this is not one that I can just come by and see these proposed cuts and not really think about how quickly this will start to impact every single one of our communities. Thanks.
Senator May.
So, I mean, I'm going to join the chorus. And the reason for that is because you're absolutely right. This is not just a job. You're caring for individuals, because I used to do this job for almost 4 years. And you're caring for individuals. And I remember, the people that I was caring for always liked to go to DAHAB. That was exciting for them. I worked in the behavioral health part, and I worked with high functioning and, what we call low functioning clients. And my high functioning clients, DAHAB was something that they looked forward to getting ready to go to every day. And you have to have a heart. I remember leaving there. I was a college student. I cried because I felt like, who are going to take care of my people? Even though I knew as a student I had to continue my little career climb and all of that. But yes, these are what I call a very sensitive group of individuals, and they need people who love them and care for them. And when you get the wrong people in, the quality for those individuals diminishes.
Senator Crawford.
Same question as before, as far as administrative versus provider. Does all the money go to the provider? Is this same as before, where it's another line?
So this also includes all of their overhead costs, because there are overhead costs here. So this is going to include rent for buildings. This is going to include their automobiles. This is going to include insurance for all of that. This includes electricity. We all know that and the cost increase for that. So that is all factored into the rate. So there's a lot more in this rate.
Do you have like breakdowns of
We
kind of what that?
absolutely do.
Could you get that to me when
We
you have a
can.
chance? Okay,
Yes.
perfect. Thank you.
Yes.
Okay, Director, go on.
Okay. You did have one more question. You asked us what factors we used considered in determining these proposed rate reductions. One of those I talked about. These are the two highest level services that we have. These are also two services, like I talked about earlier, we pay services on a rate range. These are services, our residential service, which is our largest service, is paid at 92.67% of the lower bound rate range. So we were looking at services that were paid above that, and these services are paid above that level. So those are the kind of the factors that we looked at whenever we worked through this. Also, we did a survey of 96 day hab providers across the state, and we recognized that their staffing ratios, while we're paying a 1-to-1 staffing ratio, they are staffing at a 1 to 2.67 on average. So those are the factors that we used to put these options forward.
Okay, thank you.
Yep. Okay, now, I am going to turn it over to Lisa, and she's going to go through our other new decision items and changes in the department, in the director's office book, and then we'll move to the other divisions.
Good morning. My name is Lisa Histy. I am the budget director at DMH. So we'll go through the director's office budget, like Val said. That starts with the department-wide items on page 7, and I need glasses for this. This is the environmental goods and services new decision item. The governor recommended approximately $550,000, and this is for ongoing inflationary costs for medical care and food and state-operated facilities. Page 10 is the medication cost increase. The governor recommended $2.9 million. He is recommending a portion of the mental health reinvestment fund to fund a portion of this, and this is for an inflationary rate increase for medications, contracted pharmacy and advanced practitioner services, and includes cost to continue from the supplemental. On page 14 is the FMAP adjustment. The governor recommended $4.1 million, and you will see corresponding federal core reductions throughout the Medicaid programs. This takes us to our director's office core on page 17. The governor recommended $830,598 and 7.82 FTE. There is a 20% E&E core reduction. The governor recommended this amount of reduction in all administration and regional office sections in DMH. The core on page 23 has no changes, which is overtime. The DMH contracted staff was one-timed in FY26. However, there is a new decision item on page 33 for contracted staffing, and this was recommended for $15 million out of federal funds, and this supports anticipated need for DMH facilities to contract for temporary staffing to continue operating their facilities. Operational support is on page 35. The governor recommended approximate $13.1 million and 126.55 FTE, and this is for a wide range of administrative financial services and includes the E&E core reduction. On pages 44, 52, 57, 63, 68, 73, 79, 84, and 89, those all cores have no changes. So if it pleases, I can move to the IGT DMH Medicaid on page 94. This core is for the IGT DMH Medicaid transfer. The governor recommended approximately $323 million, and this is an accounting mechanism that is related to the Medicaid payments to draw down federal participation.
Remind me again which page.
I'm sorry, page 94.
Okay.
The governor recommended a reduction of $50.8 million, reducing the CCBHO earnings transfer due to the CCBHOs no longer earning the enhanced FMAP rate. We talked about this in the utilization a little bit. That ended on September 30th of 2025. The following cores on 99, 104, and 109 have no changes. The next change is on page 114. This is an NDI for the crisis counseling increase. The governor recommended $1.4 million federal and 1 FTE. And this is a cost and continue for federal grants for the crisis counseling program for severe storms and tornadoes that occurred in March and May of 2025. The following cores on page 117 and 122 were one-times in FY '26. This takes us to the legal transfer fund on page 127 for $1. There is no further questions. That concludes Book 1, and we can move to the Division of Behavioral Health. Wow, this seat is low. I don't know if you're a fan of Wonderful. Can I sit on the little kid table? A little kid table. It used to be a Sears catalog that I would sit on when I was a kid. Good morning, Chair Black. I appreciate having the opportunity to sit in front of you for my last budget presentation.
So you don't, the
Hoping to make
Chair
it out
Black
alive,
part
sir.
was just thrown in there. You're enjoying the fact it's your last budget.
Well, I'm hoping
Let's
I'm
be
gonna-
honest about
I'm
this.
gonna-
We're
I'm hoping-
Department of Mental Health here.
I just like I like to be transparent, sir. Yeah. So, yes, my name is Nora Bach, and I'm the director of the Division of Behavioral Health. And next to me is Amy Jones, and she is the deputy director for administration for our division. And we will get started on page. I'm going to be going back and forth between glasses and not. DBH SUD administration. So, again, I've introduced ourselves. I want to make sure that I explain a couple of acronyms that you will hear us use repeatedly. DBH stands for the Division of Behavioral Health, so we'll be using that. Another acronym that we use quite frequently is SUD, and that stands for Substance Use Disorders. But at any time, if I'm using acronyms that are unclear to you, please let me know. The DBH is statutorily responsible for assuring that citizens of Missouri have access to prevention, treatment, and recovery support services for those with substance use disorders and/or mental health issues. We raise awareness about behavioral health to include suicide and overdose prevention, and we support services in the community and in our inpatient facilities. I think it's important just to let you know that all of our treatment programs focus on 5 areas of life domains. So we're seeking stability in those areas. So in terms of outcomes, what we try to do is, number 1, reduce symptoms of their behavioral health disorder. For those with serious mental illness, that means learning how to manage their condition over a lifetime. And for those with chronic substance use disorders, that can mean abstinence or significantly reduced use. The second outcome we shoot for is gaining and maintaining stable employment or educational endeavors. 3rd, securing safe and stable housing. 4, preventing or decreasing involvement with law enforcement or the justice system. And lastly, improving and increasing positive and supportive social relationships. So we start on page 132, as I just said, and the administration item, that provides funding for our administrative staff who oversee the prevention, treatment, and recovery programs by establishing regulations, developing policies and procedures, conducting regulatory oversight. We provide TA and data analytics, and we assure financial accountability. So the governor's recommended core budget is just over $3.6 million and 31 FTE, and the difference between the department request and the governor's recommended budget is for the 20% E&E core reduction and a core reduction of a GR that is being offset with the fund swap that Val referenced earlier. And you will see that again throughout our budget reference, the fund swap. On page 139, 144, and 150, I'll go with what Lisa said. Those items have no changes between GovRec and the department request, so I'll move
I
past.
do have
Okay.
a question before
All right.
we go on.
Yes, sir.
When, on page 139, when opioid settlement coordinator.
Yes.
Tell me why that one is not just included in core administration. Is there there's probably a reason, right, that person is separated from that?
Yes, it was at the pleasure of the House, sir.
What was their reasoning when they discussed it?
I don't presume to know the,
Well, I wasn't doing it adversarial either
No.
way. I just,
yeah.
you know, was it, at my house, sometimes we do stuff because I decide to. And there's really not a reason, but Grandpa told you that's what you're going to do.
You know, if nothing else, it's nice to call attention to the fact that we do have an opioid coordinator for the significant settlement funds, who makes sure that we have 100% reporting from all of the cities and counties and other,
That's what that
that's what that coordinator
position
does.
is there. So maybe somebody wanted to highlight that.
Maybe so.
Yes.
Just as we're talking right now, just opioid settlement, can you all just give us a quick summary as to where we are in terms of opioid settlement dollars as we look at some of the cuts here? I think it's good for us to have a good understanding as to, obviously, you guys gave me a document yesterday on this, but just share how much money's left, how long do we have to spend it?
You have it on you?
We're getting it out. We have it. Yeah, we have
Okay.
Or we can follow up with that information also, whichever you.
No, I think it,
No,
well, I think it's
no.
good to walk through it.
Let's go ahead
Yeah.
and take the time so everybody on the committee can hear it. I think it's good
Yeah, that's
that
fine.
we hear it.
Okay.
I think
So,
we've
and we can
discussed
share
this in
with
my
the
office
committee,
as well.
And we can share this document with the committee as well. And we update this regularly. So from calendar year 2021 to calendar year 2025, the state opioid settlement funds that we received were $213.5 million. We project in 2026 to receive another this is really small, $40.3 million. So we know that expenditures through FY25 have been 71.3 million. So 213 minus 71.3. In FY26, we have another $80 million of appropriation that could be spent, and we won't know until the end, obviously. So that's what 80 and 70 is $151 million out of $253 million in the fund. So that kind of lays that out for you.
You
So-
spent 80 when?
Well, 80 is, if we spend all of the appropriation this year, that would be 80.
Okay,
We
okay,
won't know
that's
that for a while,
FY20,
yeah.
okay.
So
But please-
80, yeah,
As we're discussing spending
Yes.
80,
yes.
and we have a count over here, we've forgotten this once in a while. We have a count over here with X number of dollars. It took a little while to get there. We're spending out of that, but here just a few seconds ago, you said about 40 million coming into the
This year.
account this year.
That's correct.
Is that dollar amount going in continually going to decrease would
So-
be my guess?
We have it projected through calendar year, or 2033 to 2041. And, well, we have that in total. So we have it projected through calendar year 2032. And so this year we're projected 40 million, and then it drops to 27, and then it goes to 37, and then it goes to 36. So it seesaws, but if you wanted to look at an average, and I'm looking at them all, I would say an average of 30 million over the net between now and calendar year 2033.
Yeah. So I asked that question to remind us
Right.
that if we're spending 80 million, we decide to spend 200 million this year, we're going to
Cut things out of the
eliminate that or backfill it with
Right.
something else, those
Absolutely.
decisions. So,
Yep.
okay.
And just for record, the opioid settlement funds are actually appropriated in multiple agencies. So there's opioid settlement funds in mental health, and we'll talk about those. Health and Senior Services, Public Safety, Corrections, Social Services, the Judiciary, and the Office of Administration. And the FY27 governor's recommendation is $66.3 million of opioid settlement funds.
I don't expect you to know this answer. I want to believe that there are still court cases out there, though. So if people go back to saying, well, what you said is wrong, there are open cases yet, but we don't know what the
Right.
outcomes of those are
Also,
gonna
another
be.
thing that we know happens with the opioid settlement fund is the manufacturers or whoever is charged will pay early. They'll offer to pay differently so that they don't have to pay over such a long period of time. So we could also have an increase one year, but that'll be a decrease in another year, so.
I only want to say, I'd like to get a copy of that opioid settlement.
We will make sure the whole committee has it.
Senator May?
Yeah, and the opioid settlement money, is there specifications on its use?
Yes, there are specifications. Actually, they happen to be on this sheet of paper also. So treatment, prevention, and other abatement strategies, first responders, training. So we always tell people, if you're in treatment or prevention, you're probably in a good space.
Okay.
And we did we closed reporting yesterday. We had one more locality that reported yesterday. So we are at 100% reporting. We have some localities that have, so we're cleaning that reporting up. Like some localities have reported more than they have actually gotten. So we're, cleaning that up with them. That happens. I mean, it's okay. So we're going to be cleaning that up. So we should have how the localities are spending the money available by March. And
I have a preview.
Do you want to give a preview now?
I have a preview. So what we went ahead and did is ran through, and this is the beauty of that position. They check, again, with all the cities, counties, municipalities who are part of the settlement. And pending final reconciliation with the last reporting, the total of all the Missouri subdivisions, their expenditures have only equaled 20% of their total settlement receipts. So some of the, reporting agencies have spent all of it. Some have spent none of it. We do have a great website. I would refer to anyone to. I'd refer anyone to if you're interested in how your county or city is spending their opioid settlement dollars. But that information is also available on our webpage.
And we're really grateful for our partners in the localities. I mean, they
Yeah.
are working with us on this. But
Their settlement's same thing, though.
Yeah.
It's not
It-
forever.
No, and
No.
and theirs even ebbs and flows differently than the state settlement
Does
does.
it?
So
Okay. Probably won't be the last question, but it's one more thing. This agency and other agencies constantly got some partner out there somewhere checking us to see how we're spending the money, and that is true in this as well.
Right.
My understanding. Who is that person? Have they okayed Missouri spend, at least the state spend to this point? And is the state also responsible for the municipalities being checkmarked okay? And if the municipalities or whoever that money goes to locally, if they, I'm going to use this technical term, screw up something, is the state the one on the hook for that, or it's go? So there are about 3 questions there.
okay, I'm going to do this high level, and then I'm going to have us write up a really nice answer for you on this. So high level, there is a settlement administrator. So that's not the federal government like what we're typically used to, but there is a settlement administrator. And so the settlement administrator has the opportunity to do that monitoring.
How much are we paying that person?
That's all out of the settlement, so we don't have anything to do
Well,
with
yeah,
that.
we are,
Yeah.
because we're not getting that money.
Right,
but
right. We're
yeah.
not getting that money. But that's all part of the
Not it.
settlement, and
We're
I
not
am
it.
not a part of that. It comes off the top, I believe, right? So that there's a settlement administrator that has that responsibility. If the settlement administrator thinks that what you're doing is not appropriate, they can start revoking settlement dollars, so to speak. So I've not heard of settlement administrators doing anything across the country with that, but if that has happened, we can let you know. And we have somebody who knows all of these answers really, really well and can write that up.
Senator Nerman.
Okay. This has been helpful. Again, there's a lot to unpack here and the implications. But I do want to talk a little bit about some of the cuts that we see or the recommendations from the department using opioid settlement
Right.
funds.
And she will get to those
So
individually.
can I just jump the gun and ask real quickly? Do you mind?
Sure.
In terms of, let's just talk high level.
Okay.
Prevention versus treatment. What's the ROI on prevention versus treatment? What,
I don't know that that's a easily answered question. Prevention certainly is you're front-loading some costs with the hope that you don't develop issues later on. I think treatment is effective, but obviously you're working against, clinical and physiological and social issues that have, impacted you up to that point of having a substance use disorder. So there's a place for both, and I think that's why the settlement is very clear in terms of its the the opportunities available under the prevention line and as well as the treatment line. So
Okay.
both are important.
And no doubt. However, we know, I mean, again, I think everybody understands that it is, if we can prevent somebody from becoming addicted, it's going to be a lot cheaper than treating
Yes.
them later on. And again, when I look at some of these cuts, $1 million for the Prevention Resource Network, again, using opioid funds. And then again, the opioid community grants that are going out to the tune of $7 million. And so when I look at this now, and, you know, Senator Henderson and I've talked about this quite a lot, we're facing a whole nother issue right now with opioids being, you know, available in gas stations right now in the form of 7-OH and everything else. I mean, this is, I would really like the committee to take a look at this in terms of those prevention dollars, and that we have those dollars now versus waiting until the situation gets even worse. So another thing just to highlight, I think, as we look at cuts, and again, this isn't GR, we're looking at those opioid funds, and I think it's really important that we continue to support prevention as much as we can.
Okay. I'm sorry. Okay. I think we are at, where are we at? 155. Okay. That is the SUD Prevention and Education Services item, and the governor's recommended core budget is just over 18.2 million and 8 FTE. The difference between the department request and the governor's recommended budget is due to core reductions to the Compulsive Gaming Prevention Fund, which is appropriated at the same level of funding, but in Department of Public Safety, House Bill 8, and a reduction being offset with the fund swap on page 231 that we'll get to. On page 163 is a new decision item basically for grant authority of $800,000. The governor recommended that we have authority just in case we get a federal grant, which is called the First Responders Comprehensive Addiction and Recovery Act grant, which will pay for training first responders and community groups in the administration and distribution of opioid overdose reversal medications. We were supposed to hear about this last fall. Communication is basically sort of fizzled out. On page 166 is the Prevention Resource Network. The governor did not recommend funding for this core item. On page 171, we get to the very interesting opioid community grants. The governor did not recommend funding for this core budget item. And just to highlight some of the reductions that impact the substance use disorder and FQHC cooperations, there were many grants for prevention and recovery. There was a Lincoln University prevention program impacted, as well as a DOTS Plus Mobile. That's actually a first responder sort of pilot program. Deaf Lead and the family recovery programs. On the there's a new decision item on page 176 called the St. Louis Opioid Overdose Reduction. The amount requested is $556,500, and the governor recommended funding this from the Opioid Addiction Treatment and Recovery Fund to continue this initiative that has been going on in North St. Louis City and County. This portion of the total appropriation was given to us as one time in the FY26 budget. So this item represents a cost to continue at the current funding level. On page 179, there were no changes. This was naloxone, no changes between the department request and the GovRec. On page 184 is a naloxone saturation increase of $8 million, specifically from the Opioid Addiction Treatment and Recovery Fund. And this item represents a request to maintain level naloxone distribution in Missouri. This was also one-time funded in FY26. This, our naloxone is distributed to every city, or every county in the state of Missouri, so we are hoping to continue to support naloxone administration training and the distribution of naloxone kits that are used by law enforcement, first responders, hospitals, and many other groups.
I want to ask a question here, see whether I know anything or not. Shelf life on this product, is that accurate?
There is a shelf life on this product.
Is it like a shelf like milk or like frozen meat in a freezer forever?
Somewhere in between the two. I think, I want to say 2 to 3 years, but please don't quote me on that. I would
Okay.
want to get you something accurate. And it's just like something on your shelf, which has an expiration date. It's best buy, but these things can go longer.
Go longer.
But yeah,
Okay.
do you want specific
And-
information from the package about that?
No, but I want one more thing around that. And I don't believe, Department of Mental Health is not charged with distributing this product and moving it around the state, right? There's some other source that takes care of that.
We contract.
And we hope that if they send some to Fairport, Missouri, that nobody knows where that's at here, I doubt, or New York, that's where I'm going to be buried. We send it to New York, Missouri, and it sits there in a box for a year and a half. Do we hope that somebody's coming, getting that box at New York, bringing a new box back, maybe with one in it, and then transfers it to some other place that is using it? And I may be asking something I just said. You guys are not in charge of this, but does anybody know
Well,
my
there's a
answer?
number of questions wrapped up in that, so let
No,
me.
there's not. Is there some
think these are
overall
compound
person
questions.
out here that decides that stuff's about out of the shelf here, we ought to move it somewhere else and take them back some? Or
Well,
not?
let's start with the first one. The first one is that we contract with an entity through the University of Missouri St. Louis. It's called Missouri Institute of Mental Health. And they have been charged with the center distribution list. We use them, DHSS uses them, and they are tracking where all of it goes. They let people know what that shelf life is. We don't have people going back around to rotate stock. It's a term I use from, yeah. So that part is not true. I think it's all about informing the recipient of the expiration date. I have not heard of any concerns about the naloxone not being used and having to be considered ineffective. It goes off the shelf pretty quickly. Does that help? Okay. On mental health prevention on page 186, there were no changes between department request and governor recommendation. And on page 191, I'm going to start a conversation about recovery support services that will encompass both page 191, 197, and 203, but you'll also hear about it in later sections. So this term gets confused a lot. Recovery support, and if you're okay with this, I would like to pull all three of these sections together. Recovery support is an umbrella term, and I like to see it that way. It's about ongoing support after somebody's maybe had clinical interventions or completed some sort of formal treatment, or it can be individuals who are looking to maintain recovery throughout their lifetime. But under the umbrella are recovery support services which are delivered to an individual. So you, Senator Black, I might provide you with transportation or peer coaching or something like that. But what's also under the umbrella of recovery support are centers that we call recovery community centers. And these are locations. So whereas one is an individually delivered service, sometimes group services, the RCCs, as we call them, are places where folks can go to get job preparation, to get peer interaction, to go to support groups, to have sober activities to engage in. So all of those come under the umbrella of recovery support. But for this particular section, the governor's recommended core budget is just over 10.9 million, and the difference between the department request and the governor's recommended budget are core reductions that are being offset with the fund swap new decision item. There's also a reduction here for NAMI peer support of 100,000 and EPIC peer recovery of 250,000 of general revenue. So I'm going to skip then past those other recovery support items and go to page 214, Recovet Healthcare. This funding is being reappropriated to House Bill 17. Page 219 is substance use disorder community treatment.
Senator May.
So I'm going to take you back. I stepped out of the room. My apologies. We're talking about the recovery support services, and you told me we did a offset on those, right? Okay, so they're going to be backfilled, or they're going to be.
We're going to talk more about recovery support services later on when we get to that fund swap and SUD initiatives, so you'll
Very
hear me
good.
talk about it again.
Yes, I'll let you do that. Thank you.
Again, I think on page 219, that's where we're at on SUD treatment. The governor's recommended core budget is nearly $113 million and supports 20 FTE. The difference between the department request and governor's recommended budget is due to reductions totaling almost $7.7 million. This does include adjustments due to FMAP and a $4.4 million offset with the fund swap through the new decision item. The true reduction of this House bill section is about $3.2 million, and it includes a reduction for housing liaisons, a project called Reducing Recidivism through Medication-Assisted Treatment, and our disease management outreach programs. On page 231 is the fund swap we've all been talking about at just over $14 million. And this item utilizes the brand-new Mental Health Reinvestment Fund to support some of the items that have been added to the budget since voters approved Amendment 3 in November 2022, so the cannabis tax funds. This new Mental Health Reinvestment Fund will receive an appropriated transfer from DHSS's Health Reinvestment Fund, so exactly the same name, we just threw a mental on the front of it and put it in our budget. And so some of the items were moved over from there, which we'll get into much more now on the new decision item called DMH SUD Initiatives on page 234. This item is approximately $4.5 million. As we said, it moves some funding lines to mental health that were at DHSS, and in recent budgets, the DMH has been the recipient of grants funded by DHSS's Health Reinvestment Fund. And this item includes funding for peer respite services, recovery community centers, and behavioral health liaisons that assist youth and adults. Items that were previously funded in health budget through the cannabis funds that were not transferred over to be supported in this budget include $6 million in recovery support services, $1.3 million in prevention, $3.2 million for a variety of substance use disorder treatment, and a $500,000 cut for peer respite. Peer respite was funded, but there was a small cut from, not a small cut, I mean, $500,000 was cut, but the total appropriation for respite is now 1.5
Out of that fund.
out of that fund.
So, I'm sorry, Mr. Chair. So on the pure respite, how many agencies we got that do pure respite?
We have,
It's the best form.
I'm going to go through the names and the locations. Will that work? It's just stuff instead of just counting. We have ARCA in St. Louis. We have Living in Victory, LIV in St. Louis. We have Into Action, Columbia. We have an Ozark Recovery in Branson. And we have Simmering Center. No, Ozark Recovery, sorry, is in Springfield. That's a typo. And Simmering Center is in Branson. That's where we have our peer respite programs currently.
It should be one more. We're missing one. And you have ARCO in St. Louis and Live and
Into Action, Ozark Recovery,
okay.
and
So
Simmering
those-
Center.
Okay.
5.
So and we're doing a $500,000 cut.
That is what's recommended, yes.
So there's no backfill or replacement anywhere for that?
Not for the 500.
Okay, because the best form, the best way for individuals to recover is peer recovery. You got that, don't you? It's like, the quickest, most effective way is when they have people who are partnered with them, who have been walking that walk for a long time.
I think what's notable about peer respite for those who are not necessarily familiar with the program is that it's very low barrier. So many times programs you have to have been sober or not using for a certain period of time. Peer respite accepts you where you are and brings you into a 24/7 peer operated environment. There's a lot of outcomes we can offer to you related to that program should there be further interest.
Okay, I'm further interested. Thank you.
Yes. On page 237 is the inmate revolving fund. The governor did not recommend this item. We do continue to communicate with the Department of Corrections about this fund and its balance. Okay, we have on page 240, page 245, page 250 are all sections that are no changes. So we can skip those or we can go through those.
Give me the number. Senator May was more important than me listening to you at that point in time.
So page-
I hate to say that on microphone, but I did.
It happens. Engaging patients in care coordination, there's a typo on your tab, is on page 240. Recovery High Schools is on page 245. And the gambling addiction support is on page 250. And again, there were no changes.
Okay, I have somebody that I work with that brings up Recovery High Schools fairly regularly.
Yes, sir. We do have a.
And I'm just asking this question blank overall. I think I know the answer. I'm doing that. Recovery High School was something that was appropriated, I'm going to say 2 years ago, maybe 3 years ago. And it's been one of those things, a fairly slow process to get to the point. So I don't care whether you answer the slow process stuff actually, but I believe there's been now contracts let on this. Tell me where it's at now.
There are 3 proposals currently that have been submitted to DESI.
Yeah.
Okay.
The state school board has approved the 3 schools, and so now we'll be working on getting those contracts in place.
Recovery High School, when some people think about that because it says high school, they think about it being like our traditional schools.
And there is one traditional school that
There
is
is one traditional school, but getting those contracts let go doesn't mean that people have to wait till September or
No.
August. Start dates, a wag on that, could possibly be as early as,
So we're working with DESI. They're the ones who actually write up that contract. We just are the funder. Is it not on?
no, it's not that. I thought I saw Perry walk in that corner.
well, let's
so
have
he
him do
could
it.
hear his question. Okay. Thank you, Director.
Mr. Chair, please, on the Recovery High Schools, so 3 contracts that they are reviewing, but how long, once they approve somebody, does it take to get up and running? So, and the question is,
So
again.
we're not looking at a start date till, it won't be this school year. I don't know if it will be next school year.
FY28 maybe?
FY28 maybe, and I think
So
like.
what is this 10 million, the 10.4 you
Okay, so
then
there's
for
federal
FY?
here. That federal is just if you can earn Medicaid. So I need people to not think about that federal as an
And then the other is opioid. I
Opioid,
saw.
yes.
Okay, but so what is, but I guess my question is if they're not going to be up and running until
we can still
FY28.
pay for it. So there's going to be like Cape High School is one of the high schools, Cape Charter School District. They've got some structure things we're gonna pay for, and then we go through to the contract of actual running the school.
Okay, can we just have some more information about that? Because this is.
We can work with our partners at DESI to get you that. So we are a payer, is who we are here. Okay.
Okay.
Right. That's why, because DESI can't spend it.
All right, if we're ready, we'll go to page 255, Addiction Medicine Fellowships. SUD fellowships have been developed to support medical providers who are specializing in the field of addiction, which is really cool. The governor's recommended core budget is $1 million. The difference between the department request and the governor's recommended budget is due to a reduction of $304,000. On page 260 is the FQHC SUD medication-assisted treatment. The governor did not recommend funding for this core budget. On page 265 is mental health community treatment. The governor's recommended core budget is just over 123 million and 30.5 FTE. The difference between the department request and the governor's recommended budget are reductions totaling 8.6 million. This includes adjustments due to FMAP changes. The true reduction looks to be about 8.1 million and includes cuts to parent ombudsman services, mental health professional training, family-to-family programs, a county coordination hub, housing liaisons, CCBHO FQHC initiative, disease management outreach, and healthcare homes. A portion of this section is also being moved to the House Bill 8 budget. On page 276 are forensic mobile teams, and there were no changes. On page 281 is FQHC mental health services. The governor did not recommend funding for this item. On page 286 and page 291 is the Mo Connect system. One is a crisis module and one is a referral module, and there were no changes made to those sections. On page 296 is health transport reimbursement. The governor did not recommend funding for this item. On page 301 is the ETMS PTSD pilot. The governor recommended the same funding as the FY26 core. Recommended core budget is just over $6.2 million.
At this time, it doesn't seem like any money's been spent out of that, this fund for this year. Am I right on that or not?
I believe the contract is still in place.
It is in place, but have we been sending money to that group or not? Okay.
We believe a new contract's going out very soon. Page 312 is patients post-discharge. Oh, sorry. What'd you say? 307, sorry. Yes, 307 is patients post-discharge. This was one-time funding that was reduced for FY27. On page 312 and on 317, these are both related to a 988 capacity grant, giving us authority. There were no changes. On page 322 is a 988 services cost to continue of just over $3.8 million, which provides ongoing funding to support our 988 services in Missouri. This item was one-time funded in FY26, therefore cost to continue is being requested in order to keep our system going. The governor switched funding from general revenue to the newly created Missouri Crisis Services Fund, which, drum roll, is on the very next tab, page 325. The Missouri Crisis Services Fund is a $37 million item, and this request provides appropriation authority to support 988 services from this new fund. It's proposed to receive revenues through the establishment of a monthly 988 surcharge. These funds could ensure ongoing and sustainable funding for Missouri's crisis continuum of care system. Establishing a surcharge aligns with federal authority and provides a sustainable solution to meet our growing demands, which are growing. And currently there are associated bills that have been filed in the House and the Senate associated with legislation for the monthly surcharge. On page 2.
Okay, let's stop.
Yep.
I want you to repeat the last part one more time on the microphone so people listening, I'm sure the committee members that aren't here are paying attention on the microphone. The value that this could possibly have, and if you can put any context right now in what other states that this might not be a brand new idea to do something like this to help fund our 988. It's not an idea that just showed up here, dropped from the sky someday. So
No.
a little bit more context to that so the people sitting here can hear that and those people listening.
Absolutely. So when the federal legislation came out for 988, it did include provision for states to go ahead and be able to charge fees or surcharges to be able to support this statewide. What's being proposed currently is 65 cents from each end user for prepaid and monthly postpaid per access line on phones, and the 1 year projected revenue is $41 million. 6 states and the District of Columbia have pending legislation related to 988 funding in addition to us. And then 42 states have passed some type of legislation related to the funding of crisis services. So it's not apples to oranges, but most states have acted to move forward on the preservation of crisis services in relation to 988. And the funding for this item includes the 988 call centers, but that's just the beginning. It also includes mobile crisis response services and behavioral health crisis centers. And as I mentioned, there are associated bills that have been filed for this in House Bill 2763 with Representative Black and Senate Bill 1562 with Senator Lewis. Any further questions?
From the committee? Good. Thank you.
Thank you. On page 320,
Yes, Senator May.
I'm just making sure this, the crisis service fund is different from the children's service fund, right? Very good. I'm just clarifying.
I appreciate your efforts to clarify. We don't want anybody not following. This is pretty complicated. Page 328 is the mental health youth community treatment. There were no core changes. On page 335 is adolescent mental health beds, and the governor did not recommend funding for this item. On the perinatal psychiatric access programs on page 340, there were no changes. And then we go to page 346, which is the CCBHO Substance Use Disorder Program. If you're not familiar, CCBHO stands for Certified Community Behavioral Health Organizations. Sometimes you'll hear us throw a C at the end. We'll trade out the organization for center. All means the same thing. The governor's recommended core budget for treatment is $50.7 million, and the difference between the department request and the governor recommendation is due to reductions totaling $11.4 million. This includes adjustments due to FMAP changes, offsets with a fund swap through the new decision item on 231, as well as funding moved to House Bill 8. The true reduction associated with this House bill is $489,000 of non-Medicaid funding. We are hopeful that pending CMS approval, CMS is the Centers for Medicaid and Medicare, we hope to approve some changes in our state plan that could potentially help us earn back funds to offset the reduction. On page 356 is the CCBHO Mental Health Adult Program. The governor's recommended core budget for treatment is $457.4 million. Again, we have FMAP adjustments. This looks to be a 5.5 true reduction to the House Bill section of non-Medicaid funding. And just as I said, with these sort of changes, we are asking CMS for approval to changes in our state plan to help us earn back some of the reduction. And on page 365 is the last of our CCBHO items, youth community. The governor's recommended core budget is $242 million. The difference being FMAP changes and a reduction to CCBHO youth non-Medicaid. And for the third time, we're hoping CMS will approve some changes to help us get some of that back. And then on page 375, we have a new decision item for community behavioral health liaisons for $500,000. This request provides ongoing support of youth behavioral health liaisons that enhance collaborative and community-based services provided to youth who are trying to navigate the system. Funding for 8 YBHLs, that's what we call them when they're working with youth, was appropriated in FY26 using one-time federal cash. As federal funds are not anticipated, we have requested general revenue to continue the services. The governor recommended half of our requested funding and an FMAP split. Did I mention this is my last? Okay. On page 3.
At least now I know quite a few more of your acronyms. So, it took 10 years, but I do understand some of them.
Page 377 is the Youth Resiliency Campus. The governor reduced this funding to offset our utilization NDI. Mental health facility support is on page 383. This House bill section allows our inpatient psychiatric facilities to utilize Medicare collections for the purchase of medical services. This core budget item is $16.8 million, and the difference between the department request and the governor's recommended budget is a reduction in authority for the hospital provider tax, which was based on a projected lapse. On page 390, it says Fulton State Hospital, but it basically marks the beginning of our inpatient facilities. And if you're okay with it, Senator Black, I could just talk about all of our inpatient facilities together. Okay, thank you. We have 5 adult forensic hospitals that are located in St. Joseph, Kansas City, Fulton, St. Louis, and Farmington, and we have 1 children's facility in St. Louis. The governor's recommended core budget for these facilities is $243 million. You know what? It's $243 million plus Hawthorne's is listed separately. And that's at $13.8 million. So the difference between the department request for these inpatient facilities and his budget are basically just reductions for tuition reimbursement expenses. 2 more to go. We have a new decision item, psychology internship program cost to continue on page 351. 451.
Is this your first time doing this?
You know you would think, sir. And it's just as nerve-wracking as it was the past 4 times. But on page 451, we have the new decision item for psychology internships of $229,000 and 5.6 FTE. Again, a cost to continue from our supplemental. And the last one is a new decision item on DBH safety and security cost to continue on 454 with just under $200 million. Again, cost to continue. $2 million to verify with the record our last NDI for DB8 safety and security. And if you're okay with it, please, can I be done now?
No.
Okay, all right.
I got
I'm up for
on a
it.
comedy show and forgot to check this one thing. Let me look again and make sure. I have questions up here. I have my sheet as well. 254, yeah, or 450.
Is this your first time?
454.
Okay.
My question is, if I remember right, I want to say this is a start for this type system, and I could be wrong. Maybe it's something that's ongoing. You don't have to flip back there. You're going to know the answer. Is this a one-time thing and everybody's going to be caught up, or should we expect this security, we've got these facilities to do next, these facilities to do next? How much are we covering with this line item this year? What's the goal? How many facilities are we covering?
Well, we want to use this fund moving forward for all facilities. It depends on when some of their security items get old, can't be,
Okay, so we're updating current,
safety mechanisms.
but this dollar amount's not going to update every facility that
No.
is in line.
No.
It will be on ongoing.
It helps us
expense.
with
Is this the
emergencies.
first? This is even the first time it's been in the budget in front of me, or I forgot that.
Yes, sir.
Okay. Thank you.
Go ahead.
We had some one-time funding for safety and security. Was it fiscal year 25, I believe?
Okay, so there was some done somewhere else at that point in time. Okay.
And sorry, I'm just gonna say the 1.9 million is actually a portion of that goes for all of the facilities, all of our inpatient facilities.
Okay. A portion
To
of it
cover
does
certain
go
things.
everywhere. It's not taking care of these
Not
two,
just one facility.
one.
No,
But one may
Okay.
pop up this year, another one may pop up it's just,
they all have need. They all have safety and security needs.
Yeah, I figured that with technology. Then there is much need with Big Chief tablet and number 2 pencil, as I do now with a computer. Okay, thank you. For those people listening, sitting in front of me, we're going to take a really short recess. I don't want you to leave. I'm going to talk to the people up here with me, and then we'll be right back.
thank you. Why would it go off?
I was like, but I didn't mean to kick you. I was an